And we're live on the air. Welcome, everybody, to Progressive Parenting Network's broadcast of the Seduction of Induction. I am super excited about tonight's show because the last time I did it was a little over 5 years ago with my dear friend Lisa Garten, who is joining us tonight. Lisa is a pediatric nurse, a Lamaze instructor, a doula, was my doula and my mentor. And she is now a certified nurse midwife, which I am super excited to say. Like, I'm just beside myself. And we are here joining you live to talk about...
We're live on the air.
Oh, well, goodness.
Welcome, everybody.
I have an echo.
Ready to Progressive Parenting Network's broadcast of the Seduction of Induction. I am super excited about tonight's show because the last time I did it was a little over 5 years ago with my dear friend Lisa Garten.
I think I took care of that problem.
Okay, good.
Got rid of it, I think. I think I did. I hope I did.
I hope you did too.
That's okay. We're all good now. It's always weird to hear yourself. Anyways, so I'm here live with Lisa. Lisa, thank you so much for joining us tonight.
Well, I'm glad we finally got this together. I still can't see you, Gina, so I miss you.
Well, just imagine me like the best you've ever seen me look. And then just,
sweet.
Yeah, hold that there because I don't look anything like that right now. but I want you to imagine me that way.
Okay, great.
I'm 9 weeks postpartum and feeling every bit of it.
Well, you know, it is one of those things that the older you get, it takes a little bit longer to bounce back. I definitely noticed the difference from postpartum at 25 and postpartum at 39.
Oh my God, is that it? Because, dear Lord, after I had Jack, like the birth really was not a big issue. 3 hours, pretty quick. I'm not going to say easy. I certainly felt like the universe was coming out of me. But the recovery kicked my butt. Like immediately after I had him for a good 6 weeks, I felt like, did anybody get the number of that truck? I got ran the hell over by that birth. Oh my goodness.
Well, you know, it takes a little
41.
longer. And you have to remember, when your body's older, too, you have the added responsibility of more children to take care of. It's not like, you know, the first or second baby. You're taking care of a lot more kids, and sleep deprivation, I'm sorry, as you get older, it takes its toll.
Oh my goodness. Well, I am certainly not a spring chicken anymore, but very happy to have had that baby. And speaking of having that baby, somewhere around 38 weeks I started losing my mind because I was so sure the baby was going to come anywhere between 36 and 38 weeks. So right after 38 weeks I was like, okay, now. Okay, how about now? Today would be great. Okay, tomorrow morning. Okay, tonight then. Okay, maybe tomorrow. And
that was a little wicked twist to that pregnancy, wasn't it?
Oh, you know, it's another lesson I'm supposed to learn, and the universe is trying to teach me something, and oh my goodness, it was a good lesson for me because I went 41 weeks, and I get it now. I think it was humbling for me. A lot of my clients who'd gone 41 weeks, 42, 43 weeks, yeah, you know, I heard all the complaints and I heard all of the crying, and I'm just so done being pregnant, and I get it now. I get it.
You know, all my babies were 41 plus weeks. You know, they were all 41 to 42 and 3/7. So I'm definitely a crock pot, not a microwave. And if I had 5 more babies, they'd probably all be late. And I'd be on the other end of the spectrum. If I went into labor like at 38 or 39 weeks, I'd probably be kind of freaked out because I would maybe not feel ready.
Right? Oh my gosh. Yeah, no, this was crazy for me, and it was a good thing too. It was good because I learned a lot. But I think what I learned the most now is I get why somebody offering you to let your baby come at a certain time after you're so done being pregnant can sound really amazing. Like I think if any of my friends said, I have a magic wand that I can wave and it won't harm you or the baby, I'd have been like, okay, yes, please.
Well, and that's how induction is presented, Gina. And I can't take credit for coining the term seduction of induction. That belongs to the awesome Penny Simkin.
Right.
But it really is a seduction because yeah, if you had someone that had that magic wand, but you said kind of a key thing here, isn't going to cause any harm to me or my baby. Um, and unfortunately, that is how induction is presented so often. Is it's not that such a big deal. We do it all the time, and you come in early, we'll break your bag, we'll start some pit, and hey, you'll be holding your baby by dinner time. That's often how it's presented. There is no true informed consent, just a true seduction.
Right, and that's all that is presented. I know that when I was induced, I went into the hospital with Ava. This is 11 years ago, and it's funny when I tell the story. Someone said that sounds like you could have had your baby yesterday. I went in, and I went in because I was bleeding. I had taken the hospital childbirth education class, so I wasn't told about.
Lucky.
Yeah, and I sat in the front row with a pen and pencil. I was ready to go, and I wrote everything down. And I never heard them say anything about bloody show. So I had show, and I was freaking out. I was sure that something terrible was happening, and I went in, and they said I wasn't even having contractions, and they said, "Oh, how exciting! You're going to have your baby today." I said, "I am," and they said, "Yes, you are. We're just going to give you some pitocin." And it'll get your contractions going, and then we'll have a baby by dinner time. Because I went in
Yeah,
at
see, you got that one too.
I was very excited about that. So I did ask, a smart girl that I am, if pitocin was going to harm my baby. And she said, "Oh, no, everybody gets it. You'll be just fine." So that was the extent of my informed consent. And I told myself, like, I didn't even know what it was. They didn't really tell me that it was a synthetic form of oxytocin. In my mind, I was being given like a vitamin because it sounded a lot like potassium. I'm not kidding. I'm not proud. That's what happened.
Hey, that's just normal though, Gina. I mean, when you think of the knowledge base of the majority of American women as far as what information they're given, what information they have access to, that's a pretty normal scenario.
Yeah, and I look back on it, and I was really, I was happy with my hospital birth. I really was. And it wasn't until much later that I found out all the things that I wasn't told, and then I was upset. Because I really would have liked the opportunity to make the decisions that I did make based on some real facts. I was really upset by it. And a friend of mine was like, "Well, nothing happened." Well, yeah, nothing happened. That's like, driving in a car really fast for a couple of hours without a seatbelt on and nothing happening. And I got lucky. I really did. I had every intervention under the sun and managed to come out with a vaginal birth and a second-degree tear. But it was I would have really have loved to have had informed consent. So I think the folks who are watching right now would want to know what we're talking about. Like, what's the big deal about being induced? There's a lot of different ways that you can be induced. Thank you very much. So let's talk about that. I want to talk about the number one way.
Methods.
I'm sorry?
I said about induction methods.
Yeah, all the different types of induction methods, because I think a lot of times people hear or think pitocin as one of them, but there are a lot of different methods to induce someone. So let's maybe we can talk about them from like the mundane to the scary.
Well, kind of one of the first criteria, is your cervix even favorable? And I think that's information a lot of families just don't have or know to ask. But, induction with a favorable cervix, which means your cervix is anterior, it's already pulled forward, it's effaced, it started thinning out, and it's preferably dilated a little bit. All of those different items, and including the consistency, is it hard like your nose or soft like your lip? All of those play into something called a Bishop score. And essentially a Bishop score less than 6 isn't going to give you a real favorable cervix for induction. So, you know, if you've got an 8 or a 10 Bishop score, it's highly possible that a whiff of pit will get you going without too many issues. So I would say first thing is and that's an intervention, is what is the cervix? How is it favorable? Once we've decided you have a favorable cervix, then some of the methods that can be used are pitocin, like you said, starting pitocin. You can also break the bag of water. Sometimes that can kick in labor. That's a method a lot of practitioners use, is breaking the bag and starting pit. If the cervix isn't favorable, then they can use a product called Cervidil or Prepidil, which are basically a prostaglandin that's applied to the cervix that helps it ripen and make it softer, makes it more favorable, so that when you use pitocin, you have greater success. And then a very non-pharmacological form of induction could be a Foley catheter, which is typically what we put in your bladder to get urine out, but it's pretty wonderful because it's soft, it's rubber, it has a little balloon. So we can put it in the cervix if it's a little dilated and gently blow up the balloon. So it kind of applies some mechanical pressure, and that can help soften the cervix. And then either labor starts spontaneously, or you can add pitocin to that mix. And then a very often used method is cytotec, otherwise known as misoprostol.
All right.
So you did scary, so I ended with scary. So
yeah, I know, right? I was wondering if you were going to catch on to that or not. Well, let's start from the beginning. I think I see on Facebook a lot where people say, "What are normal ways to induce?" I hear that a lot. Natural labor inductions, and to me, when I hear natural induction, I think oxymoron.
Yeah, it is.
That's for me, because I think when you're talking about inducing someone, then you're talking about making something happen before it's normally or naturally ready to happen. So a natural, quote-unquote, induction is still an intervention, no?
Yes, it is. And I understand, I'm not going to say I'm 100% fan of, but I understand the rationale, because a lot of families that are wanting a home birth or a birth center experience, once they get past that 42 weeks, they risk out. And so if your desire, if your plan is to have an intervention-free birth at home or in a birth center, and you get to that 42 weeks on the dot, it's kind of almost like a grieving process, Gina, that sets in, because you see what you want kind of slipping away and being taken away from you, and feeling like you have no control over it. So to me, when people are asking for, natural ways to induce, for a reason like that, it kind of makes a little bit more sense. But at the same time, you're right, it's still an intervention. And as a crock pot, I can tell you, I tried everything. Ultimately, I just finally went into labor. So, when we look at the actual evidence is where I always like to go. The actual evidence on all of these different methods doesn't really show that it shortens the time of labor. So, if it's things that can't really hurt you, like having sex, a little bit of nipple stimulation, go for it. It can help. Semen has prostaglandin in it. We know the prostaglandins help ripen the cervix. So, that could help you and pretty much can't hurt you. So for that one, I'd say go for it. Um, Everything else, you always have to look at what are the benefits, what are the
Go
risks.
quick.
I mean, even good old castor oil has some risks to it. So, you have to have, again, informed consent, even for what we consider more natural methods of induction.
Okay, yeah, I'm glad you brought that up because it sucks when someone wants to have a normal birth or natural birth in the hospital or in a birth center, and once they hit a certain amount of time, then they're no longer eligible for that, and that sucks. It makes me sad because I wonder how many of the people who are planning on those type of births know that ahead of time, and I wonder what their backup plan would be if they knew that ahead of time. A lot of times.
I can't speak for all places, but I did do part of my preceptorship at a birth center. And, this is something that we start discussing at 40 weeks. We start discussing, what's going on, benefits and risks of going post-term, which, by the way, post-term is not until 42 weeks. 41 weeks is not post-dates by ACOG's own definitions. So, we do talk to parents about that. And kind of the main thing I always stressed was trying not to stress about it because, stress hormone does not help you go into labor. So when you're pumping out cortisol and adrenaline, your body essentially is seeing a hungry lion standing in front of you. And no smart body would let a baby out with a hungry lion standing there. So, I recommend things like massage, hot bath, getting comfy with your partner, and just giving into the process because it really is like, the watch pot doesn't boil. Yeah, the watched uterus doesn't contract.
Yeah. I know that to be super true. And in my classes, I make sure to share with young doulas, the idea of getting to the house really soon. When you get there really quickly, you're just another person watching her. I like to get there. I like to get there when there's lots of stuff going on. I tell my class, when it's just a super juicy time, when there's nothing else, nothing's going to stop. When you get there and nothing's going to stop the birth. Once it's a train going a million miles an hour, then I like to show up when I know I'm not going to, when no one could stop it if we wanted to. But if I get there too early, I just feel like another set of eyes on her going, okay, when's it going to start?
Well, yeah, and birth is not a spectator sport, so,
Yeah,
there's
absolutely.
a lot of truth to that. Occasionally you will run into a client, though, that is just very anxious, and sometimes going over early doesn't result in a baby being born, but sometimes hooking up with your client early results in putting them in a hot tub, letting them relax, putting them to bed, and then doula either sleeping on the couch or doula going home and sleeping in her own bed until things kick off. So,
absolutely. So let's talk about that. So that's like kind of the benign stuff we're talking about, like sex as a way to do that. But what about when we get into I see on Facebook people saying, "Oh, you should try some oh golly. We were in the play together. We were in Birth the Play together." And she talks about taking it, and she said that she had cramps and then poop.
Oh, castor oil.
Yeah, thank you. I drew a blank.
You got the lines right, though. Good job. I'm impressed.
I only did the play 4 times, and I never took castor oil once, but people were saying, "Oh, you should take castor oil," and all I could think of was the character from Karen Brody's play. Poop and cramps. Poop and cramps. Oh
you
my
get
gosh.
the picture.
Yeah. I totally got the picture, and I said, "No, thank you." And by the way, I am now friends with Jillian Tamoya on Facebook, and my life is complete.
Oh my goodness! I will have to find her.
She's amazing. So let's talk about castor oil. The good, the bad, and the ugly, and would you do it?
Well, the ugly is, you're pretty much a hostage of the porcelain god, if castor oil is doing its job. So does castor oil bring on labor? Well, there's some people that'll swear by it. Research doesn't really hold a lot of clout there, but the rationale is that castor oil irritates your intestines. Your intestines get rumbly, as anyone who's taken castor oil will attest to. Your uterus kind of sits, on top, around, side by side, all of those intestines. And so that movement can cause your uterus to get irritable and start contracting. Kind of the way that a bladder infection can bring on preterm labor because of the proximity of the bladder. So that's kind of the rationale. And we know a UTI is, a major cause of preterm labor. So rationale-wise, it kind of makes sense how castor oil might work. But there's never been, like a double-blind, randomized controlled study. But is it a placebo effect? Do you think it's going to work and therefore it works? Or did it really work? Or did you just finally give in to labor and it would have happened anyway if you hadn't taken the castor oil and pooped your brains out? So, I can't really answer that one.
Okay. All right. So let's move on to the next one. Let's talk about, because I've seen this before as a doula at home births, where a midwife will say, you've been in labor for a while. Why don't we just go ahead and break your water and get things going? And the mom says, "Oh, okay." Without, and I've heard it, and I haven't heard any informed consent going on. Where all I heard was mom being told that it'll get things going, but nothing else.
And that's pretty seductive,
Sounds good.
Does breaking the bag of water shave some time off of labor? I'm thinking about the research I've read. I think that they show with amniotomy, maybe, oh gosh, to try and quote numbers directly, you know how I am about that. But
right.
It was less than an hour. I want to say it was like 55 or 56 minutes difference. But again, it's not really a randomized controlled study. So would things have changed anyway? What other interventions took place as a result of amniotomy? The technical term for breaking your bag of water. All I know is we can't see your bag of water. We can't see exactly how the cord is inserted into the membranes. And it kind of depends where you are in your labor. If I've got a gal that's 8 or 9 centimeters, the baby is low, and she's got a bulging bag, just bulging out, bulging into the vagina, and she's interested, I'm not going to bring it up. But if she's like, can't we just break this bag and get this baby out of here, I might feel a lot more comfortable with that than somebody asking me the same thing at 6 centimeters. At 6 centimeters, I would probably be more inclined to say, this is the purpose of the bag. It protects against infection. It cushions your baby's head while it's pressing on the cervix. We don't know where the cord is. One of the risks is cord prolapse. That's one of the major risks. One of the other major risks is if that cord is not inserted in the normal place. And I've seen a lot of cords in a lot of different places. We don't know where those vessels might transverse or traverse across the membranes. And if you pop a bag and catch a vessel, that's pretty much an obstetric emergency. So that would kind of be my discussion about that. But amniotomy is frequently used as a means to speed up labor, supposedly.
Right. But yeah, I never. That's like not the conversation I've ever heard, either in the hospital or at home births, where mom has given this option of, hey, we can get things going. All we have to do is get this little needle out and just, do that. It takes a second. Doesn't really hurt you or the baby, and we're ready to go. And there is no discussion about what could happen. No discussion about cord prolapse. No discussion about the chance of infection. Now that we've broken the water, now you're on a time clock. I never hear anything like that. It's just presented as like not a big deal, no big whoop. And I don't think that's fair, because my birth is kind of a big whoop to me. And it should be brought up if there's any chance of my baby being hurt. I kind of want to know about it.
Well, and I think, when you look at a very medical managed birth, because as a student midwife, I had the wonderful opportunity to spend part of my time in a very high-tech, high-volume, high-intervention practice, and then spend time at a birth center. So it really was a very nice marriage of seeing both sides up close and personal. You know me, so of course I really liked being at the birth center. But that being said, I did develop a strong respect for when things can go wrong in birth. And, home birth clients, birth center clients, those are like what I call the cream of the crop clients. They're healthy, they take good care of themselves, they've invested time and energy in proper nutrition and exercise. Those are our elite mommies. Unfortunately, in the more public sector of life, the women I encounter frequently don't do any of those things. They smoke, they eat crappy food, they're diabetic, they're anemic, they don't exercise, they haven't even thought anything about their birth. So, I can see where that medical management does sometimes come in, because sometimes it has to, but there's a lot of times that it doesn't have to. And interventions are not always presented with all sides. And I think all families have that right. You need to know, how is this going to affect me or the baby? Regardless of what birth setting you're in, regardless of what type of attendant you have.
Well, I'm glad you said that, because that brings up a universal treatment. A woman walks in and she could be, have taken care of herself really well and done all of those things that you had stated, and gets treated exactly the same way as a woman who comes in who just found out she was pregnant at month 6 and never didn't change her diet, didn't stop drinking or doing drugs or whatever, and both of them are going to get treated the exact same way.
Yes, and unfortunately, because birth is often looked at as an accident waiting to happen in the hospital, and unfortunately, there are things that I saw that frequently the medical staff, and that's funny, I've been a nurse for 21 years, but I often did not consider myself the medical staff. Often you would hear, oh my God, they're so lucky everybody was here, and we're so lucky we were able to take her for emergency C-section, or oh my God, what would have happened if this had been a home birth? I frequently had that presented to me, because people knew I, sat on the other side of the fence much more comfortably. But in my mind, it always kind of appalled me in, how can the rest of you not see how the things that we did contributed to this outcome? And it just clearly, it's just not seen. And, the other thing I would like to point out is, a lot of times obstetricians and ACOG get a really bad rap, and I invite people to really research ACOG's position on many things, because there are many, many things that the way obstetrics is practiced is not in alignment with ACOG recommendations. There's a lot of picking and choosing going on about which things to follow, and induction is one of them. ACOG does not recommend inducing before 39 weeks at all, unless there are very clear-cut medical reasons. They don't recommend inducing for macrosomia, so that, oh my gosh, if we wait too long, it's going to be a big baby issue. That is not a recommendation at all. So that was one of the things I think that shocked me as a midwifery student. I'm like, why are we being forced to study ACOG stuff? This isn't midwifery stuff. But then when I started dissecting things, I realized, wow, holy moly, they really do understand what's going on. They have acknowledged the research, and in fact, this recommendation is very different than what I see being practiced.
Well, yeah, just recently, and I know a lot of midwives and doulas haven't had a chance to see this yet, but just recently, ACOG just came out with the Safe Prevention of the Primary Cesarean Delivery. ACOG and SMFM came out with a new thing, and I talked about it at great length with Dr. Stuart Fishbein not too long ago, and my question is, why are obstetricians acting like this never happened? Does ACOG put something out and OBs have a choice to pay attention to it or not? I don't understand.
Yeah, that's basically it. They make, that's something about medicine that a lot of people don't understand. There are guidelines, there are recommendations, but they are exactly and only just that. They're not law. No one can force a practitioner to practice a certain way. They can say, these are the guidelines we suggest. These are the recommendations we promote. But ultimately, it's up to the individual provider to A, stay up to date on current research, which many do not do, and B, choose to embrace or not embrace the current recommendations and the current guidelines.
So would it be an advisable idea or a suggestion that your client asks their doctor, when they first realize they're pregnant and they're looking for an OB, do you abide by the current research that ACOG puts out? Or, I'm not sure the right way to put it, but do you pay attention to what ACOG says? Are you up to date on what's happening? When was the last birth conference you went to?
Well, that's kind of a loaded question, and I don't know that you would necessarily always get an honest answer, because that's just kind of like a yes-no question, and I don't really like closed questions like that because it doesn't tell me too much about what the person's thinking. So maybe a better way to approach it is, tell me about your thoughts about ACOG's induction recommendations. Or tell me how you support ACOG's recommendations on prevention of the first cesarean. So kind of spicing it up a notch, and that lets the person you're talking to know that A, you know a little bit, and B, you want to know what they know.
Oh, boom. Can you imagine? Oh, my goodness. Talk about being put on the spot. Wow. I'll tell you what, if they can't answer your questions, they sure as heck might want to think about being ready to answer that for somebody else, that's for sure.
Well, it's really funny, Gina, because, I work at a federally qualified health center. So we work with, the underserved individuals. And, I love working in that arena because I feel I have the opportunity to make a lot of impact to people that may not have access. All families in America don't have access to the best birth information. Let's just be real. But if you have limited resources or you have language barriers or you have educational barriers, then your access is even further reduced. So we have another CNM at our practice right now, and I recently started teaching Lamaze for these individuals. I finally was able to kind of finagle that as a free class for our clients. And the midwife called me last week, and she was cracking up laughing, and she goes, "Wow, I can tell you're teaching Lamaze now." She goes, "In all the time I've been here, I have never had someone sit down and say, 'Can you tell me about your philosophy on induction?'" And she said it kind of caught her off guard, and it at the same time made her feel really happy that they were a young couple, and she was just really happy that they thought enough to ask a question. And of course she took the time to sit and talk with them, which was really, really awesome. But in the clients we serve, that's not typical. It's just not typical at all. They frequently just go along with whatever the program is, and their expectation is that we'll just tell them what to do and how to do it and be okay with it.
And why wouldn't they? We're supposed to trust you guys. We're supposed to trust the doctor. We're supposed to trust the institution that is there to take care of us. Why would we question anything? Why would we think to question anything? Don't y'all know what you're doing?
Yeah. Well, it's just kind of like everything else in life. Don't be sheep. It doesn't really matter what it is. It's probably a good idea to always ask questions and be informed and do a little research on your own, and not just jump in because everybody else jumped in.
Word. So let me I've got some people asking me questions live that I want to share with you. By the way, this
okay. I can't see anything, so.
Yeah, you can't see anything, and if you could, all you could see would be me nursing Jack right now, because this is.
Oh, hi Jack, enjoy.
Somebody was saying, we were talking about the seduction of induction. She said, what do women find seductive about taking a drug that makes contractions so painful that they feel like they're dying? Isn't childbirth painful enough? Why do we need a drug that makes it 50 times more painful without a break? Aren't women researching pitocin and what it does in labor? So yeah, she's talking about pitocin, and I think we might want to, unless there's another form of induction that you want to talk about before we get into induction. I mean, induction with pitocin.
Oh no, going there is fine. And what's seductive about it is, well, just like any other good seducer, you don't tell about all of those things until after you've already seduced the person, right? You don't.
Yeah, like I didn't tell Craig that I snored in my sleep until after it was too late.
Exactly. There's some things you just don't reveal. That's part of the whole issue of seduction, because seduction is a glamour. Seduction is whatever you want the other person to see. And so that's how families can be seduced. And the seductive part is, A, I get to meet my baby now. B, I don't have to be pregnant anymore. C, I feel like I'm never going to have this baby, and I am just flipping tired of being pregnant. And D, why would my healthcare provider offer me this if it wasn't a good thing? Right?
Right. No, absolutely. That's the thing, and that's why it is seductive, because the whole truth isn't being told. It's just the quote-unquote sexy part, which is the baby in your arms right away. And I think the other part of that is, someone brought it up earlier on my Facebook page, women think that, like, oh, you're going to get your baby, and then your baby will be in your arms, and then everything will be like it was 9 months ago. And they're not being told that, yeah, there's a recovery time. There's a time where you're going to feel really tired, and you need to take care. Like, it's like, what's the big rush to that? You know what I mean? And I can tell you, though, regardless of whether it's your first time or your fourth time, it doesn't matter. Because when you're in it, when you're in that 41st week, you're just done. You're not in your rational mind. You are somebody completely different. Who I was almost 9 weeks ago when I gave birth, or just 10 weeks ago, the week before I gave birth, is not who I am right now. I'm sorry to say that this is me rational. I'm still not 100%. But here I am in one mind, and I was not of the same mind 10 weeks ago. Really. If you gave me, like, you tell me, Gina, this is a special gum you can take, and the baby will come today, I might have done it. Give it to me.
Give me a big wad. Will it work better if I put it anyplace else? You know.
Right. I don't care. Tell me where to rub it. It's
great. Here, you choose too.
Your pregnant brain is not a rational brain. It's a brain, but it's not rational. So it's easy to be seduced, and I think it's easy for us to sit on the sidelines as birth professionals or just other moms and be like, what's wrong with her? Why didn't she research that? Or why didn't she blah, blah, blah? You're just in a very vulnerable place. And things that your best friend can say, or your doctor, or hell, some stranger on Facebook, if it's something you want to hear, you're going to listen to it. Because you're in that
and it's
vulnerable
just human nature. I mean, I'm sorry. It is just human nature. When you're feeling vulnerable, it's human nature, not just for birth, but for a lot of things. And yeah, hindsight is always 20/20. Always. Always. But when you're the person in that moment, it can be really hard. And, you know, I know with my first baby, I felt like I was just never going to have a baby and be pregnant for forever. And then had a fast birth. And with my second one, I kind of figured, okay, yeah, I'll just be pregnant for forever. So that part wasn't so shocking. But I had a lot of anxiety about having a fast birth. And then I didn't. And with the last one, I just figured I really am going to be pregnant for forever. And, you know, I think I was at the hospital 20 minutes before he was born. So, but I didn't have any anxiety about the baby coming fast, or even if the baby had fallen out at home, I would have been perfectly cool with that by number 3.
Right.
Because I knew a lot more things than I did previously. You know, you're always adding to your toolbox. And what I have found in working with families is if you started out with a really lean toolbox and you made choices and decisions either based out of fear, because fear, you know, we have to be honest that unfortunately sometimes coercion is part of how some of these different interventions are presented. You know, I've actually heard a provider say, well, you want a live baby, don't you?
No.
When a family was not interested in augmentation, which is pretty much like induction, except you're already in labor, but you're not, you know, cooking along fast enough, so we're going to speed it up a little bit. We're going to microwave a little bit here. You know, so there is some, you know, a lot of coercion that can come in there. And that brings up the fear factor. And when you're a vulnerable individual already, and someone throws in the fear factor, that makes it even harder to make, you know, very good decisions, Gina. And when people find out later, kind of like you found out about pitocin later, you may have had a really good birth experience, but then if you find out later that some of the things that happened maybe really didn't have to happen, or oh my gosh, you know, that could have gotten really scary. I'm really glad that it didn't. But some families get kind of angry, you know, at that point. It's like, why weren't we told this? Why wasn't this information available to us ahead of time? And I think that's probably part of the reason that you and I do the things that we do, because we've heard those stories too frequently.
Yeah, absolutely. That's totally my story. So let's go ahead and talk about pitocin. Oxytocin, I'll just start here. Oxytocin is your body's natural hormone. It's secreted in bursts. However, when you're given pitocin, you're placed on a regulated intravenous pump to regulate the amount of pitocin in a steady flow. Okay. Therefore, pitocin-induced contractions are different from your body's natural contractions in strength and in effect. So they're longer and stronger. With pitocin, you also receive
stronger, and closer together.
Longer, stronger, closer together. So with pitocin, you'll also receive continuous electronic fetal monitoring, and this is because fetal distress is more common with pitocin use and needs to be detected if it occurs.
Correct.
We've also witnessed that pitocin can be what's the word I'm looking for? The very first domino of the domino effect. And that's kind of how I want to start talking about pitocin. What it is exactly, I think it's presented as something benign, and somewhere like 60 to 80% of women are induced with pitocin and not told what it is and don't know what it is. I'd like you to speak more to that.
There's a whole piece of pitocin issues, Gina, that, I'm always looking at things in life and thinking, in 20 years, what is going to be the thing that's our aha moment? And I really feel that this is one of the things that 20 years from now, all of a sudden we're going to go, aha, maybe that wasn't such a good idea. The recent article on how pitocin can maybe affect babies. So what we know, oxytocin is made in your brain. It is released in a pulsatile fashion, like you've already said. So you get a little, you have some contractions. You get a little more, you have some more contractions. Mother Nature has its own gatekeeping way of giving you enough to keep things going, but not giving you too much to make things crazy. I also like people to remember that pitocin is really a key. To think of it, oxytocin is a key. Excuse me. Think of oxytocin as a key. And this key is made to unlock certain locks. And some of these locks are in mommy's brain. Some of these locks are in baby's brain. And some of these locks are in the uterus. So the thing that your body makes is in no way, shape, or form even remotely similar to what is in the IV bag. Okay? That's number one. It's just not the same thing, folks. Sorry. Pitocin in a bag can do one thing. Make your uterus contract. It does not do anything to cross the blood-brain barrier for mom. It has no keys to unlock anything for the baby. It just is specific to the receptors on the uterus. That's it. So that's kind of one of the first problems, because oxytocin is integral in the activation and the awakening of the mommy brain, for lack of better words. Okay? For the baby, it is unlocking things in the brain that we're just scratching the surface of understanding. And what we know is a baby will never have a higher oxytocin level ever if it's a boy. If you're a boy baby, you will never ever have an oxytocin level the same as you experience at birth. If you're a baby girl, the universe has given you a second chance, because if that baby girl grows up, becomes pregnant, gives birth, a normal birth, with her own oxytocin, her brain can unlock some other stuff. But baby boys, really, they don't ever get another shot. That's it. Birthday is it. Anything that's going to get unlocked happens that day. I'm sorry, Jeannie, you were going to say something?
Oh, no, I said, did you hear that, Jack? And then I made a sad face.
Why? You gave him good oxytocin.
Oh, no, I did. But that was his one shot.
Yeah, that was it. We've always thought women, we were a little bit of the superior species. It might be true if you look at oxytocin. So that's number one. The other issue with pitocin, like you've pointed out, it's in an IV bag. You get it and in a regular infusion. So you're getting the same amount of milliunits per hour cranking out. A woman on pitocin has to be monitored. It is just not safe for you to be on pitocin and not have a fetal monitor on. Okay? So if you're wanting a low intervention birth and you're like, oh, I want to do intermittent fetal monitoring, I want to use the shower. If you're lucky enough to, be in a facility that has the use of birth tubs, you have to be on a monitor. It is not safe to use a PIT without a monitor. And I think a lot of people don't know that those two things go hand in hand, so that's important to know. But pitocin definitely creates contractions that are longer, stronger, and closer together. And ideally, we like to try and get those contractions 2 to 3 minutes apart. Just boom, 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 boom. I can stand in the labor bay, and I call it the labor bay at a large hospital facility, because there's a huge board that has tracings of everybody's fetal monitors, and you can look at it all in one place. So if you're ever wondering why are all the nurses at the nurse station, it's because they can see everything that's going on. But I can stand there and look at the board, not know dippity-doo about any of the patients. I can look at the labor patterns and tell you who's on PIT and who's not. Because Mother Nature is just not that entirely perfect. When I see boom, 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 no variation, I know that patient's on pitocin. I see hills and valleys, little tweaking here and there, little pause here and there. I know that patient doesn't have pitocin. So yeah, you can tell just by looking at the fetal monitors. So pitocin, if we give you too much, contractions are too strong, too close together. Well, okay, so what's wrong with that? It's just going to get my baby here faster, right? I mean, that's the whole purpose.
Right.
Yeah. Well, your baby, while it's, going through labor, is trying to get something very important called oxygen, and your placenta is delivering that, and your placenta isn't really delivering oxygen during a contraction. It's during the rest phase when the lakes are able to fill back up that the baby gets good delivery of oxygen to it. So that's the importance of the rest in between contractions. That's a recovery time for the baby. Pain-wise, pain threshold-wise, it's a recovery period for the mother. So the cascade for mom, pain relief is usually requested with pitocin. And it's not a shocker that women getting pitocin are asking for pain relief. And if you went into labor wanting a normal labor or a natural birth, not using drugs, you've gotten pitocin, now you're left maybe feeling like a weenie because you're begging for an epidural, when it makes good sense why you would beg for an epidural.
No, absolutely. I'm glad you brought that up, because not knowing when I went in, knowing 100% that I wanted to have a normal birth, not understanding how the pitocin was going to affect me, somewhere around 6 or 7 centimeters, I was hurting, and they were saying, okay, look, you're going to get an epidural now or never, because the gentleman who's going to administer your epidural, who I ended up referring to as my knight in shining armor later.
Oh, yes, Dr. Magic.
Yeah, Dr. Magic's going home right now. So the anesthesiologist, there was a window apparently for me, and everybody, I looked to my birth team, and they were like, oh, dude, I think you should do it. I think you should go for it, because you're looking, like this hurts a lot, and you're not even at a 9 or 10 yet. So according to these guys, if you get to 9 or 10, you're going to wish you were dead. So just do it. Do it now. And I was like, you know what, that's good advice. Let's go ahead and do it. And I did. But and I've seen my clients have a pitocin and not get an epidural, and I'm like, holy wow, you're amazing. But that's asking your body to go through a lot more than it would have naturally, I think.
Yeah,
and
I mean,
you wanted a normal birth, it kind of mostly can go out the window once you get that pitocin.
There are times pitocin is necessary. You know, if you're having a medical induction, there is a reason that we need to get the baby here sooner. There's a issue with baby or there's an issue with mom. There are some legitimate reasons for inductions. I don't want, people to think that, we're saying,
Absolutely.
oh, you should never have an induction, because there are true medical reasons to have one. But that being said, going low and going slow with pitocin has actually been shown to give better results. And, to me, ideally, if I have to do something like this, it would make sense to start the pitocin and go very slow with it. During those first 2 hours, increase it very, very slowly, not jack it up every 15 minutes. Give your body some time to start really reacting to it. Once contractions start, a lot of people don't know that they can ask for the pit to be turned off. Sometimes what I like to call a whiff of pit will get you going. Then we can turn it off and your brain takes over. Your brain says, oh crap, we're in labor. All right, let's juice up some oxytocin here. And then that
Right.
nice little loop starts. You have a contraction, it gives you discomfort, your brain releases more oxytocin in response, you get some endorphins, then all of the players jump on board. And you can have a fairly normal birth at that point. Once you've been off pitocin, and as long as the baby's looking good, we can do intermittent monitoring at that point. You can use the shower. You can get in the tub. So, there are ways, I guess what I'm trying to say is there are ways to use some of these things more judiciously when they need to be used and pay more attention to, what mom and baby need at that point.
So I want to talk about that. I think it's not, I'm not about vilification of hospitals and doctors. I think the biggest enemy for me is misinformation, not knowing what
totally.
the things are. That's my biggest problem with things. I'm not against doctor and hospital. I'm so glad that they're there. I am against not knowing what's happening to you. And I just am hoping that folks get informed consent and are looking for it. And you alluded to something earlier, and I think you were talking about the study that found adverse effects of pitocin in newborns that was published by ACOG, the American Congress of Obstetricians and Gynecologists. If you are a doula or midwife watching right now, or a parental advocate in birth or birth advocate, you want to go to acog.org, about ACOG. Just Google ACOG and study adverse effects of pitocin in newborns. I'm just going to read just a tiny bit for you. Induction and augmentation of labor with the hormone oxytocin may not be as safe for full-term newborns as previously believed, according to research presented today at the annual clinical meeting of the American College of Obstetricians and Gynecologists. Researchers say this is the first study of its kind to present data on the adverse effects of pitocin use on newborns. Given intravenously, pitocin, a brand of oxytocin, is often used to start labor when a pregnant woman is overdue. It's also used to keep a lagging labor going by increasing the frequency. So what they found, essentially, is that induction and augmentation of labor with oxytocin was an independent risk factor for unexpected admission to the NICU lasting more than 24 hours for full-term infants. Augmentation also correlated with APGAR scores of fewer than 7 at 5 minutes. So essentially what they're saying here is that pitocin was affecting babies.
Well, and it's kind of a chicken and, the chicken or the egg issue here is, does the actual pitocin affect the baby? Most likely not. But does the use of pitocin affect the baby? Because it decreases placental perfusion to the baby. And that is most likely the issue, because when we stress a baby out and we interrupt oxygen flow, then yeah, you're going to have bad APGAR scores. That, they can do cord gases and blood pH and things like that in newborns, and it kind of gives you a good baseline on how stressed out were they at birth. And that is what happens with pitocin induction or augmentation. When we go too fast and too hard, uh, babies are the ones that definitely are, taking the brunt end of it there. Mom is either climbing out of her skin at that point or has gotten an epidural, which she totally deserves at that point. But, I think that's something families don't look at either, is, okay, now mom's comfortable. We made mom comfortable. She's cool. She's doing all right. Junior or juniorette is experiencing everything exactly the way they were before you got the epidural. So the epidural helped you, you're cool, but it did not help them at all. And the other issue that's going on here, Gina, is when you're using PIT, like we talked about, the other chemical brain players are not being brought to the table. And we know that endorphins, catecholamine, adrenaline, all of those things help a newborn, help a baby during the birth process be able to transition to life outside the uterus. All of those things are necessary for the baby. And when we take away mom's pain, we take away endorphins. When we take away pain, we take away adrenaline. We may or may not take away all of the catecholamines, but we've probably knocked a lot of those out of the ballpark too. So, I'm glad the study's out there and that it, revealed that, yes, we see differences in the babies. But I think a better explanation for families in general kind of needs to happen so that they understand how all of these pieces affect the baby and affect the birth.
Right, giving them a bigger and better idea of what's really going on in birth. And I think studies like that, when you look at them from, again, there's this vilification of things. Instead of vilifying the drug itself, let's maybe shed some light on how birth actually happens. And there's so many things that are going on when everything is left alone that actually work. But the funny thing is that when you're just looking at it from the outside, it doesn't look like much is going on. And I think it's easy to oversimplify, and then I think it's also easy to overcomplicate. There has to be some middle ground there. There has to be a place where if it was explained in a way where you can see all of the different things that are happening, and that if she were in a perfect world to be left alone, how they work together. But then when we start intervening and you were making these interventions, how one thing kind of leads to another. That's the whole domino effect, because everything's connected. Everything has to be there for a reason. But if you don't know that they're there, it's so easy for you to go, oh, I just need to take this pill or do this one simple thing, and then I can have my baby. And nothing's ever that easy in life.
Well, and like you said, Gina, everything in birth is connected. You can't change one piece and not have it change something further down the line. Even when you look at early newborn transition, you look at success of breastfeeding, you look at maternal recovery, postpartum depression, all of these things can be changed and influenced along that whole gamut of birth, depending on what interventions come into play. And I don't think anyone ever really talks about that. You talk with lactation people, we'll tell you, if a woman's had an epidural for 4 hours or less, I don't see a difference in the baby. I mean, I can't tell you. I can't just look at you and your baby and know nothing about your birth and say, oh, wow, this one had an epidural for a while. To me, 4 hours, I don't see any difference at all. 8 hours, I see some subtle changes in the baby. 24 hours or more, I can almost always tell you. I can tell a mama, oh, I mean, I don't even ask, did you have an epidural? That's sad. I should just ask, oh, did you have an epidural? Instead, which is probably not the best question out of my mouth. But what comes out is, how long did you have an epidural for? And they're like, oh, well, like a day and a half. I was having an induction. How did you, and then they're like, how did you know? Well, how do I know? Because I have a baby that is completely, they're not integrated. The suck, swallow, breathe mechanism is not what it should be. They're sleepy. They're very neurologically disorganized. And that's a harder baby to parent. It's a harder baby to breastfeed. It might be a little bit more difficult to bond with that baby because the parent's not getting that super positive feedback that they would get from a baby that was completely neurologically intact. So, there's little bumps on the road all the way down that road. When we change even one or two little things in birth that people just say, oh, it's not that big of a deal. Let's just get this party started.
Okay, so I've got lots of questions going on. Somebody asked, we were talking about pitocin. So pitocin, at least it can be turned off, like you were saying, a whiff of postpartum, of pitocin. You were saying that it can be turned off. Now,
yes.
Somebody was asking me about nipple stimulation and how some doctor was saying, oh, we can't have her doing nipple stimulation because we can't turn it off.
Yeah, I have actually experienced that with a client before. They asked for a breast pump to use for nipple stim to help get their contractions better organized, and we were told that as well. Oh, well, we don't have a protocol for that because we're not sure how that's going to affect your labor, and it could bring on contractions that are too long and too strong. At which point I was a very bad doula because I just kind of laughed and I said, oh, heavens, of course, because we know pitocin never does such a thing. I think we have a fetal monitor on. Would that not let us know if that was happening? And so that was a bad doula day. If you're a doula listening, that is not an appropriate comment. But this was I have to say, it's not an excuse, but this is a couple, this was the third birth of theirs I had attended. So we were very well bonded over, like an 8-year period of time, and knew what side of the fence each other all sat on. So it was a little bit more than a typical doula client. But yeah, that wasn't the best thing for me to say. But that's what we encountered. And, the mom essentially just looked at the nurse and said, okay, well, if you don't want to bring me a breast pump, then my husband, he's really good at this, so I'll just have him be the breast pump, and you might want to close the curtain and not come in. So there you go. You know what? They brought us a breast pump.
Of course they did. So, getting away from pitocin, I think we touched on everything that we needed to touch on. So let's talk about cytotec. You and I were privileged to have a discussion with Marsden Wagner years ago on my AM radio show, and if anybody wants to listen to it, all you have to do is Google Marsden Wagner, Gina Kirby, Informed Consent, and it should pop up. And it's me and Lisa and Marsden Wagner having a really great open, of course, discussion. Marsden pulled absolutely no punches and went after cytotec. Now, I get in a lot of trouble with my OB friends when we talk about cytotec, and well, if you're my friend, you know I'm not worried about getting in trouble. So let's talk about cytotec. Now, I've heard recently from people that what we were saying before was that if you Google cytotec, you'll see a picture of the label with a big red line through it, and that the FDA doesn't approve of it, blah, 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 blah. Is all of that still true? Or have things...
To my knowledge, I've not heard anything different. Cytotec is still not FDA approved for use in pregnant women. It is This is a hot topic on midwifery boards too, Gina. It's not just in OB land. And I would say on a lot of the midwife boards that I'm on, it's a divided camp. There are some of us that are just, I don't think this is a good thing. It's not something I would choose to use at all. When we have things that are approved for use as induction agents. And then there's others that are like, it works really good. So, I can't argue. Does cytotec work to bring on labor? Yes, it surely does. It does. Can't lie to you there. That it will help get your baby out. What are the risks associated with it? Well, the fact that you're not supposed to use it in pregnant women is pretty much says it all. Unfortunately, what has happened is it's been used so frequently that it's kind of like one of those, I don't even know how to put it. If you do something, okay, let's say, for instance, you drive not wearing a seatbelt, Gina.
Okay.
You crazy woman, you brazen woman. You don't believe in seatbelts. It's like, I don't care what, all of these different commissions say. I'm not wearing a seatbelt. I don't like it. It crinkles my pants. You know what? None of my ancestors wore seatbelts. They didn't even have seatbelts in the car when my grandparents drove, and they didn't have any issues. So I'm not going to wear a seatbelt. And you could drive all over the dang United States and any place your car could take you and never, ever, ever have a bad problem at all. And your neighbor is driving, you've driven with them, and you say, why do you wear your seatbelt? That's just so passé, you don't need to wear a seatbelt. And your neighbor's like, well, okay, I guess I don't need to. They go out on a trip and get in a wreck and are ejected from the car. And everyone says, shame on you. You should have worn a seatbelt. Didn't you know better? You, on the other hand, have driven all over the place and never incurred any harm whatsoever. So, do seatbelts save lives? Yes, we know this. This is what research and statistics show. Can you drive without wearing a seatbelt and not die? Surely, you can. People have done it. Happens. You might get a ticket. Can you use cytotec to start labor and have things turn out fine? You betcha. You surely can, just like driving without a seatbelt. But, just like that wreck you never know you're going to get in and get ejected out the front windshield, cytotec can, have issues such as uterine rupture, severe fetal distress, amniotic fluid embolism. We don't know when those are going to happen. They just happen. There's not a lot of predicting factors, just like getting in a wreck on the freeway. It just happens. So, should you wear a seatbelt to keep you and your children safe? Yes, you should. Should you use cytotec just because a lot of people have used it and we're perfectly fine? Individual practitioners are going to practice the way they choose to practice. So I can't tell someone how to practice and not to practice. That's up to you. But I've seen bad things happen with cytotec myself. So does it make me a little fearful of it? Yes. Just like when I was a nurse and worked in the ER and had to take care of people that were scraped up off the road because they were not wearing a seatbelt. Does that make me click my belt every single time I get in the car? You betcha. If I see someone driving without it or a kid not in a car seat, do I come unglued? You betcha. Because I helped put those people back together in the emergency room. And it was not pretty. And when cytotec goes bad, it's not pretty either.
Well, we know that, since the early 90s, that cytotec has had some very adverse effects on moms and babies. I think, first of all, a lot of moms don't know that cytotec, I'm just going to be looking at Jack for a second and talking because he is smiling at me, that cytotec affects, that women have been dying from ruptured uteruses and their babies have been dying. We've known that since the 90s. and yet it hasn't stopped anybody from using cytotec slash misoprostol, which is the other name for it. In fact, I know that you have a story about one of your clients. You told them to make sure not to take cytotec, or you at least told them about cytotec, and they were not taking it, and then they got to the hospital before you, and they were offered misoprostol, which they said, sure, never heard anything about misoprostol, so we'll go ahead and have that. And I think it was a nurse from Hawaii that saved them from getting pitocin also.
Yeah, the dynamic duo. Yeah, she refused to hang the pit, and that's how I found out they had miso. She brought in the pit and threw it on the counter, and she goes, and I'm really glad to see you, because I was the doula that had got there. She goes, I'm really glad to see you, because you need to help them get this going, because I'm not hanging this pit, because where I come from, we don't infuse pitocin on people that have had cytotec. And I just, my eyes about popped out of my head, and the little couple's like, well, we didn't have any cytotec. And she goes, yes, my dear, you did. You've had 2 doses of misoprostol, and that's cytotec. So, A, my client was pretty PO'd because they did not feel they really had informed consent. And 2, I was grateful that we had a nurse that, she did not have a comfort level with that combination, and I applaud her, for not wanting to go there. So, they ended up having a very nice birth, but it could have been very different. Uterine rupture used to be a rare occurrence. Amniotic fluid embolism hardly ever used to be heard of before we used things like cytotec and even pitocin. So, it's a casual association, you might say, but Ina May Gaskin has a quilt, several pieces of quilt now, Gina, and I know you've seen it too, with the names of mothers and sometimes babies as well that are no longer on the planet as a direct result of cytotec. So she likes to make sure that their stories are remembered and honored and shared. And that's not something that anyone ever shares with the family when they say, oh, let's just give you a little cytotec. Now, I do have to say that cytotec, once the baby is out of the uterus, if you are having a postpartum hemorrhage, cytotec can save your life. And is that an off-label use? You betcha. So again, there's that double-edged sword, Gina. There's some drugs we use off-label that are very beneficial. There's some drugs we use off-label that there's little research on. But if you are hemorrhaging postpartum, cytotec can mean the difference between mommy staying on the planet or not, or us having to go to the emergency room and, the operating room, and remove her uterus. So, I don't want to say it has zero place in obstetric care, and I don't want a family to ever think, oh, I heard cytotec's bad, and even though I'm bleeding to death, yeah, no, I don't want none of that. Because just like most things in life, there's a time and a place. Right. And again, looking at benefits and risks, and it's a very different thing when you don't have a baby in your uterus, okay?
Yeah, absolutely. As far as that goes, though, I'm hoping you can touch on a couple of things about cytotec slash misoprostol, what it's like, where they put it, and the difference in cost between, say, misoprostol, cytotec, and pitocin. And can you stop cytotec once it starts going?
Yeah, well, that's kind of the funny thing. When you're looking at induction agents and you're thinking of cervical ripening, because cytotec can be used to ripen the cervix as well as kick you into labor. So cytotec is a pill. It was pulled from the market for its original use, which was to treat stomach ulcers. So when you pull something, and you now no longer have an approved use for it, monetarily it's not very valuable, Gina. I mean, you've got Viagra, which some people find very valuable. It's a very expensive medication. That pharmaceutical company is making a lot of money off of that. Cytotec, the pharmaceutical company, is making beans on it because literally it's like 8 cents a dose. Less than a dime. Now, when you're looking at your more approved agents, such as Prepidil or Servidil, those are much more expensive. And depending on, which institution you're at, etc., what supplier, you could be looking at a difference of something costing $8 to $18. So if you only induce one lady a day, you probably don't mind using a product that costs $18 a head, right?
Right.
If you're inducing several women a day, hundreds of women a month as an institution, that thing that cost 8 cents, well, that is a lot more seductive.
Good Lord. If we're talking about bottom line, that's pretty sexy stuff.
And, there are some institutions who shall remain nameless that do not have other options on their formulary. There are some places where cytotec is the only cervical ripening agent on the formulary. So
Is
if
that like a place like, say, Kaiser, that only has cytotec on there, are you able to ask them for something else even though they don't have anything readily available?
You betcha. If you're giving birth somewhere and you need to be induced, you're having a medical induction, and the only thing you're offered is cytotec, as a healthcare consumer, you have a right to ask for an FDA-approved product. And if that means that a courier's got to get in the car and drive across town, or somebody needs to Fed Express something, I don't know how they would do this, but they can do it. There has to be another facility. If you're in a very rural area, I suppose it could be possible that you might not be able to get something that day, but then you need to look at how important is the induction? What is the rationale that we're doing it for? Can mom or baby wait? The answer might be no. The answer might be, the benefit does not outweigh the risk. That decision can only be made at that moment in that particular case. But in most cases, I would say as a healthcare consumer, you have a right to ask for something different. Servidil's kind of nice because it's on a string like a tampon. So if mom starts having contractions that are too long and too strong, which is, hypersystole, we can just pop that out, pull it out, like all good tampons, it has string, and the effects start to subside. Even with Prepidil, which is more of a gel that's applied to the cervix, you can do some irrigation, not like a true douching method, but just with some warm, normal saline kind of flushing the vagina, and you can kind of get that washed out of there and reduce those effects. Cytotec, once you put it in, there's no taking it out. It's there. You have to wait for it to work its course. If contractions are so crazy that the baby is being compromised, we can give you a shot of terbutaline and try and knock them out, which works really well with pitocin. Doesn't work quite as well with cytotec. In what I've seen, I've not, that's not something I've researched or seen research on. That's just strictly from what I've seen with my own eyeballs. So.
Oh my goodness. So for moms who are watching right now, they're expecting, and maybe they're in their 38th week. I just had a friend of mine say that her doctor is already talking about induction, and she has gestational diabetes. and he's already talking about inducing before 39 weeks. What can moms say to their their care providers when it comes to the topic of induction? What can they do in order to get the best chance of informed consent?
Well, diabetes is one of those things, Gina, that would fall under a medical indication. But well-controlled gestational diabetes would not fall under that category. So if a woman had was not taking very good care of herself, was maybe not, if she was on, a diet-modified regimen and was not following her, the eating she's supposed to be doing, and her blood sugars are all over the place, or you have a woman that's using insulin, maybe she's even doing everything she's supposed to, but they're still having a heck of a time getting her blood sugars in rein, then there may come a point where that baby needs to be here on the planet instead of in the womb. So, I don't want to say there's never an indication for that. But well-controlled gestational diabetes, and women know whether they're well-controlled or not, is not an indication for induction or cesarean through ACOG's own, writings. So I think that's the first thing is why? Why? Why is this better? Why is this better for me? How does my baby benefit from this? Those are the questions you need to ask. And just being told, oh, well, because you have diabetes. Well, if you're GDM, you should know whether or not you're in good control or not. And if you're in good control, you bring that up. Well, my sugars have been great. You told me I've been doing a fantastic job. So why would I need to be induced just because I'm GDM? So I think always asking, always asking, always asking is the best thing you can do. And I like families to kind of think, this is one of the things I teach in childbirth class, when I'm touching on advocacy and really trying to get parents in the mindset, is as a peds nurse for 21 years, Gina, parents will not let me do anything to their babies without asking a gajillion questions. What's that? What's it for? Where you're putting it? Is that going to hurt him? Is there something different? Why do we have to do that? Can't we wait? I love those kind of questions. It doesn't bother me one iota. But what just kind of floors me is parents will be such mama and daddy bears when their baby is here, but yet during pregnancy and labor, that same mama bear, daddy bear doesn't come out. For some reason, they are much more vulnerable, maybe. I don't know what it is, Gina, but they'll go along with the process much easier than they will once that baby gets here. And I see that as a very stark difference between pregnant mama and have my baby in my hand mama. So I tell parents, when you're trying to make a decision or trying to figure out, should I ask questions, think about, what would I ask if I was holding my baby in my arms right now and you were wanting to do these same things? What would I want to know? What would I ask? What would I demand? Because let me tell you, mommies and daddies demand information when it comes to doing things to their children. And they need to have that same mindset when they're pregnant. So you're going to use it and develop it later, so just work on developing it while you're pregnant.
Yeah, I do role playing with my childbirth education couples, and it's really funny because the dad will be, or the birth partner will say, "Oh yeah, I'm gonna blah 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 blah." I'm like, "Okay, so let's go ahead and role play. I'm the doctor, and I'll just start. All right, Jeanette needs to have an episiotomy right now," and he goes, "Okay." And I'm like, "I'm not even really the doctor." Okay, let's start over. So what I'll do is I give them. Oh, what happened? My camera just went out. Can you still hear me?
Oh, I can hear you fine. I've never been able to see you, so it's no biggie to me.
No biggie to me. So what I'll do is I'll give the partner this baby doll. This is your baby. Okay, and we'll give you another example. and I'll say, all right, we want to do, we really think that she needs to have a C-section because she's been in labor for 12 hours and we don't see any changes. And his reaction is completely different holding the baby in his arms. Completely different. He gets like super like, rah! Like, whoa, what happened? It just suddenly seems more real.
Well, those protective instincts, parents just have that innate, those protective instincts like that. And, that's why I teach that in class. And yeah, I do a lot of role playing too, because it can be very intimidating to be in the hospital. Mm-hmm. In your home, if you're having a home birth, you have a lot more control. And I think your vulnerability level is different because it's your environment. And frankly, if you want somebody out of your house, you can tell them, get the heck out of my house. Mm-hmm. And you're going to feel okay doing that. Right. You get to a birth center, you're going to be more comfortable than you would be at the hospital, but at the same time, it's still not your house. It looks a lot more like your house, but there's a little bit difference in the dynamic there too, because you're a guest at that house. So you're probably going to be a little more conscious of those kinds of things. You throw a family into the hospital, and that's not their environment at all. It doesn't look, sound, or smell like any environment you've ever been before, nor do you want to be. And it's extremely intimidating. So you can have a family that maybe used to be, very outgoing and have good ability to verbalize and advocate for themselves, but you throw them off in that different environment, and all of a sudden it goes down the tube. So I think doing role-playing with clients, whether they be doula clients, midwifery clients, obstetric clients, I think that's important. I think it's a good tool. It can help them learn how to use their voice and think in a more pressured situation.
I would hope so. Well, Lisa, we've run out of time. I love that we got a chance to talk again together. I miss you. I wish we were still in the same city. I missed you at my birth. I told everybody earlier that Lisa was my doula for Uma and Charlie's births. So I went and had a baby without you, Lisa.
Oh, you know what? That I missed being there too. I was with you psychically. I was with you as best I could be spiritually. Talked to you a couple times, but yeah. it wasn't the same. I missed sharing that with you.
Well, I missed you too, and you can see later in the playback. I'm showing you the end result, and he's kind of awake, kind of asleep, but he's sweet as pie. We ended up having a home birth. It was great, but I did miss you. I miss you all the time. And congratulations on your CNM. How exciting!
Oh, thanks.
So now you get to catch babies with letters behind your name. Yeah.
Yeah, well, like that makes a lot of difference. But yeah, currently I'm waiting on a piece of paper from the state of California. That's a whole nother bureaucratic debauchery. But eventually, yeah, I'll have a piece of paper that says I can do that. So.
Yeah, I'm pleased as punch to know you. Thank you for all the things that you do for moms and babies out there, and I hope this won't be the last time we see you on our program, and that we can talk to you more about things in the future. Thank you, everybody.
Oh, you're very welcome, and you're doing awesome work too, Gina. So I'm sad you're in Austin, but I'm glad.
Well, thank you, everybody, for joining us tonight. If you have any questions about the program, please send them to progressiveparentingradio@gmail.com. If you have any ideas for new programs or want to see somebody on our show, please let us know there, or you can always find us on our Facebook page at Progressive Parenting Network or Progressive Parenting on Facebook. Or you can always find me at Facebook /MSGENA Kirby. All right. Thank you, everybody, for joining us. We'll talk to you again soon. Bye-bye.